Okay, well, I think we'll make a start. It's after just gone after 12 in Port Moresby and in Melbourne, where I am, and I think it's after 9 a.m. in Yogyakarta. So welcome everybody. We've got people today from Port Moresby and Madang and Alatau and Wewak and Mount Hagen and Yogyakarta in Indonesia. So welcome. And today I wanted to talk about vaccines and vaccine preventable diseases. And I won't teach you everything about vaccines, but I just want to cover the basics of what we all need to know about vaccines as pediatricians. And so within an hour, you can't cover everything, but we'll do as much as we can. We might have a session about other aspects of vaccines, perhaps adverse events related to vaccines at a later date. So this is what I want to talk about today, just to give you, the basics of vaccines and the expanded program for immunisations, the EPI, what we always know as the EPI. I'm going to talk about the history of the EPI a little bit. I'll talk about vaccines in Papua New Guinea, but it's really mirrored by the history of vaccines and the introduction of new vaccines in countries throughout the world. And we'll talk a bit about recent changes to the vaccine schedule and may allow you to be familiar with the current schedule, and perhaps talk about why there was some recent changes to the current schedule. And we'll talk a bit about sort of outbreaks that have occurred in the last 5 years, so you really understand why those outbreaks occurred and what was required to deal with them. I want to, hopefully by the end of this talk, you'll also understand about different types of vaccines. We use this language all the time, like live attenuated vaccines or particle vaccines or conjugate vaccines or the use of adjuvants in the development of vaccines. And I just want you to have a good understanding of what those terms mean. And then we'll update on some new vaccines that are coming or about to, that may exist in the near future. So I want to take you right back really to the notion of vaccination. And it goes back a very long way, not 10,000 years ago, but several hundred years ago. But as you probably know, smallpox was the first disease that's ever been eradicated by a vaccination program. And smallpox really was a scourge of ancient civilizations. So it probably was predominantly the cause of the decline in the Roman Empire. There were devastating epidemics all over Europe from in the first millennia and up to the 17th and 18th century, and even much of just like COVID, for example, that notion of travel takes vaccine preventable diseases to the world. Measles was taken to the Pacific Islands and to Asia by explorers and early colonists. And smallpox similarly was taken to the New World by the Crusades, so taken to the New World, that is in South America. And so really smallpox was spread around the world by the introduction of travel and colonization, and it caused devastation to populations all over the world. And it was, many people know about the story of Jenner, Edward Jenner, but the notion of vaccination goes back even before Jenner, and that is that in the early part of the 18th century, so the 1700s, it was known that if you injected a small amount of smallpox virus under the skin, then several things might happen. Either you become very immune to the disease, that is, your body makes antibodies to the disease, or you could die, or you could get bloodborne sepsis or some other virus, and so the outcome could either be good, as in you're protected against smallpox, or it could be bad, as in you die. And that was injecting a small amount of the actual the virus underneath the skin, which has been mirrored in some vaccines, but the smallpox vaccine was different. It was not injecting a smallpox virus underneath the skin. It was injecting an analogous virus called cowpox, which didn't infect humans. And you probably know that this was the story that Edward Jenner was famous for. He was a physician for whom a milkmaid, someone who milked cows, came to him, Sarah Nelms, came to him with with lesions of cowpox. And Jenner realized that the viruses were very similar to smallpox. So if you pass on the cowpox disease to another person by injecting a small amount of cowpox underneath the skin, then that could also protect you against that person against smallpox, which was the human disease. The cowpox didn't cause major disease in humans. It caused the sort of vesicular rash that you see with smallpox, but not a major life-threatening disease. So Jenner, in his ingenuity, realized that injecting a small amount of a different virus that's very similar could actually cause an immune response to the virus that causes human disease. And that's what he did. He actually injected his gardener's son. So these days, this sort of experimentation wouldn't get past an ethics committee, but he scratched the skin of his gardener's son with the cowpox that he got from the milkmaid, and then he tried to expose the gardener's son to smallpox, and the gardener's son did not develop smallpox disease. So this was the first time a different sort of virus that is similar was used to prevent a major human disease, and that led to the eradication of smallpox. And this is the certificate from the World Health Organization that indicated in 1979, in December 1979, that the world was declared smallpox free. Now, smallpox vaccination in Papua New Guinea only started in the 1960s and went through to 1976 when PNG was declared smallpox free. Now, again, smallpox probably didn't exist in Papua New Guinea up until colonization, but of course it was brought with European settlement, but it was eradicated by 1979. So this was the first big achievement by what wasn't the EPI then, but was first the big achievement by WHO in vaccinations. And since then, so since the mid 1970s, was what's called the expanded program of immunizations, the EPI. And the EPI, which we know about today, which is much more complex, started with just 6 vaccines plus smallpox. It started with these vaccines that I've listed on the left: BCG against tuberculosis, of course, the oral polio vaccine, OPV, and then 3 vaccines that were joined together: diphtheria, tetanus, pertussis. That used to be called the triple antigen vaccine. Now, of course, it's wrapped up in the pentavalent vaccine, but DTP, diphtheria, tetanus, and pertussis, and then, of course, the measles vaccine. And since the 1990s, so for 20 years, that's all the EPI was, those 6 vaccines, and it was highly successful, saved millions and millions of lives by these 6 vaccines. But since the 1990s, in Papua New Guinea, the following vaccines have been added. So hepatitis B vaccine, Haemophilus influenzae type B vaccine, and the streptococcus pneumonia vaccine, and the rubella vaccine. I'll talk about all these so you know how they fit in to the schedule. And of course, in some countries, there's been other vaccines introduced. So in Indonesia, there's the rotavirus vaccine. The rotavirus vaccine is also in Fiji and other countries in the Pacific. There's the HPV vaccine, the human papilloma vaccine, which has been introduced in many, many countries. And of course, now the COVID vaccine. And then there's some other vaccines that have been introduced in some countries. But we'll focus mostly on the first 6 and some newer ones today. Why the first 6 vaccines? Well, firstly, they were diseases that at that time in the 1970s had very high mortality and morbidity. They caused a majority of the world's childhood deaths. They were very low cost too. They'd all been developed in the 1950s and 60s, and they were low cost. They were highly effective vaccines, and they were quite safe. And so that combination of things, a disease with high morbidity or mortality, low cost, highly effective, and they were safe, meant that those 6 vaccines were chosen by the WHO as part of the first EPI, the expanded program of immunizations. So starting with smallpox, but then expanding to these other 6 vaccines. This is what the EPI looks like now, at least in Papua New Guinea. And you can see it's a much more complicated field. I'll go through each of these as we talk today, and by the end of it, we'll come back to this table where we'll talk about the current schedule and why it is the way it is. But you can see, as I say, it's a much more complicated schedule of the expanded program of immunisation of the EPI. The vaccine that was the most similar to the smallpox vaccine was the vaccine against this disease, and this, of course, is tuberculosis. And the BCG vaccine was very similar in idea to the smallpox vaccine, in that what's being injected is not a particle from Mycobacterium tuberculosis, the human form, but what's being injected is a particle from a bovine form of TB, and this was the BCG. Right, and so this is a live attenuated strain. BCG, the Bacillus calmette-guerin, is a live attenuated strain of Mycobacterium bovis, so the cow form of TB. Now, of course, Mycobacterium bovis rarely causes disease in humans, but like cowpox, but it can protect humans from getting human TB, Mycobacterium tuberculosis. It was developed in 1921, so it's now, BCG is now just over 100 years old, 101 years old this year. Now, there are many different strains of the BCG vaccine, and often we don't know what BCG vaccine we're actually using, but the BCG vaccines are all named after countries, usually the countries in which they're developed. So in terms of the efficacy, they're all different. They're somewhat different in efficacy, and I've gone from the highest efficacy to the lowest efficacy, and certainly the BCG Denmark and Japan, they seem of quite high efficacy, and then BCG Serbia and Russia lower efficacy in most studies that have been done, and the difference in efficacy is actually quite large between these two, Denmark and Japan, and down to the other BCG vaccines. They're all most effective. They're most effective if they're given at the time of birth, and they're most effective against disseminated TB disease. They're not as effective against just getting infected with TB, right? So if we have TB exposure, we can become infected with TB, but of course not get the disease. But years later, we can get TB disease. But the BCG vaccine is most effective against the disease from disseminated TB, and less effective against getting TB infection, and less effective against pulmonary tuberculosis. We know that if you immunize newborn babies, it gives the most protection. And as I said, the most protection is that if you immunize very young, and if you are protecting against disseminated or miliary TB or TB meningitis, to which the BCG vaccine is highly effective if you immunize in the neonatal period. It provides, as well as that, it provides some good protection for pulmonary TB, usually up to about 10 years after your BCG vaccine, but sometimes up to 20 years. And of course, in some countries, they give booster doses of the BCG vaccine, but that's a bit controversial as to whether or not that's of any benefit. Yeah, but in some South American countries, for example, there's a booster dose at around about 10 years in young adolescents who are at school, but that's not recommended by WHO, and it's not in all countries. Just like the smallpox vaccine, which remember was a particulate of cowpox virus. The BCG vaccine protects against a variety of mycobacterium. So there is good protection against leprosy, and also good protection against the Borrelia ulcer, which of course is due to Mycobacterium ulcerans, but both of which are are not rare in Papua New Guinea, the Borrelia ulcer and leprosy. So there is some spin-off benefit of protection against other mycobacterial diseases. We know that vaccinating in the neonatal period is the best thing, but delaying BCG vaccine increases the risk of TB. So the earlier we can give the birth dose of BCG, the better, really. And there was, I guess, when the hepatitis B vaccine first came out, there was some uncertainty about whether or not you could give them both together, and indeed you can. Not in the one syringe, but of course you can give those two vaccines at birth, and that's safe and it's best. It's optimal to do that, not to delay one or the other one, because we know that the earlier you give the hepatitis B vaccine, the better it is, and the earlier you give the BCG vaccine, the better it is. There are a few contraindications to the BCG vaccine, but perhaps not as many as what you think. So, for example, children who've got acquired immune deficiency syndrome, so HIV, who are very unwell, who aren't on antiretroviral therapy, then they shouldn't get the BCG vaccine if they've got impaired immunity or if they've got some congenital form of immune dysfunction. But if a child with HIV is stable on ART, if they're clinically well, if they're immunologically stable, if their viral load is relatively low, it's suppressed, and if their CD4 count is okay, then the BCG should be given. That's a time when it's very effective for those children. But of course, you shouldn't give it unless those conditions are met for children who've got HIV. If a baby is HIV exposed but well, that is, we see a lot of HIV exposed babies that are uninfected, and if the mother's on ART, then it's likely that if the baby's well, then they should get BCG vaccine. If the baby's exposed, HIV exposed, and has any clinical signs of HIV, if they've got thrush or if they've got failure to thrive or chronic diarrhea or recurrent pneumonia, of course, that child is likely to have active AIDS, acquired immunodeficiency syndrome, and therefore it wouldn't be safe to give the infant BCG. But if they're well and they're on ART, then they should get it. If in pregnancy, it's not recommended to give BCG, but it is recommended for lactating mothers. It's fine for mothers who are breastfeeding to have BCG, and it's fine for preterm or low birth weight babies. This is one area that people in the past thought we shouldn't give it to. Perhaps we shouldn't give it to preterm babies or low birth weight babies, but in fact, it probably is highly effective if you give it in neonates, and it might also protect them from other infections. It's possible that it does that as well. Okay, that's all I want to say about BCG vaccine. We can come back to it if you like. I wanted to talk now a bit about polio, and the reason I wanted to talk about polio, this is Dr. Winnie Sadoway, who many of you know, and this is with the first patient from the recent polio epidemic. This was a couple of years ago now, of course, but this was the first patient that was reported in the polio epidemic, and this was a very big deal, of course, having a polio outbreak. And I wanted to try to explain why the polio outbreak occurred, so you have a good understanding of what that was. As I said, just like in 1979, WHO declared the world, including the Pacific and Asia, smallpox free, and the world, and Papua New Guinea was declared polio free in 2016, after the last case of wild type polio, that is the circulating wild type polio virus, was detected in 1999. So it's only 22 years since the last case of wild type polio in Papua New Guinea. But as you know, there's major efforts for global eradication of polio, and it's been successful to the point that wild type polio virus type 2 and 3, there's 3 types, type 2 and 3 has been largely eradicated. And because of that, the world shifted from using oral polio vaccine, that is polio, previously we had what was called trivalent OPV, trivalent oral polio vaccine, that contained polio viruses 1, 2, and 3. Polio OPV being a live attenuated vaccine, right? We shifted from trivalent to bivalent, to just 1 and 3. And the reason why we shifted was because poliovirus type 2 is a bit more likely to cause, rarely, vaccine-derived polio infection, Right? It's a live attenuated vaccine, so it's estimated that somewhere between 1 in 5 million and 1 in 15 million doses of the vaccine will lead to vaccine-derived poliovirus, and I'll explain why sometimes that occurs. So the shift from trivalent OPV to bivalent OPV was to try to eliminate the risk, the very, very rare risk of vaccine-derived poliovirus. And then WHO recommended that we start the use of IPV, that is injectable polio vaccine, which contains all three polio types, but it's inactivated. So it's not a live attenuated vaccine, it's an inactivated vaccine, and it therefore can't cause vaccine-derived poliovirus. And so the reason for that was because if you've got some poliovirus type 2 still left in the community, then the IPV, the trivalent IPV, which contains 1, 2, and 3, will be able to mop that up because it's inactivated. So these days, we've introduced a booster dose of IPV at 3 months because that reduces the viral shedding of the OPV, the live attenuated vaccine. And that's why we give 3 doses of OPV and then 1 dose of IPV. And now there's 2 doses of IPV, one of which is given, the second one of which is given at 9 months. So the schedule looks like OPV 1, 2, 3 and IPV at 3 months and then at 9 months of age. Right? I just want to talk a bit about the vaccine-derived poliovirus outbreak and explain why that occurs and how rare it is. This is a graph of the number of cases of acute flaccid paralysis that were reported in Papua New Guinea. And you can see that 2018 and 2017 were very high rates of reporting of acute flaccid paralysis. And in May 2018 was the first case of acute flaccid paralysis in Ley. That was that boy I showed you before. And he had vaccine-derived poliovirus, but it was type 1. So vaccine-derived poliovirus type 1. And in June, the Department of Health confirmed an outbreak of polio. And the reason it occurred is because of very low vaccination coverage. So if you've got, if you've been vaccinating with OPV for many years, but you have very low rates of vaccine coverage and you have poor sanitation in communities, then there'll be fecal oral circulation of the excreted oral polio vaccine virus. And that over many, many millions of doses and millions of cycles of circulation can lead to some genetic variation that leads to increased virulence. So the polio vaccine is entirely safe, but if it is circulating in a community because of poor sanitation, then just like any virus can mutate hundreds and thousands and millions of times, and occasionally that virus can mutate into a virulent strain. And so that's the reason why there was an outbreak of a relatively small number in the end, but an outbreak of polio in PNG in 2018, 2019. So there were 6 rounds of mass polio vaccination in 2018 and 2019, and in total there were 26 cases. So a relatively small outbreak, but very important to get on top of. There was one death in one child, and other children's recovered. Many were, of course, had ongoing paralysis. But by the end of 2018, 97% of children less than 15 years of age had been vaccinated. So a very impressive response that led to the highest rates of vaccination that we had ever seen in 2019. Very impressive. And so I just want to explain again why the vaccine-derived polio outbreak did occur, and that is because OPV oral polio vaccine is a live attenuated polio virus, and it replicates in the gastrointestinal tract, and it, just like any other virus, causes an immune response. You get a response from lymphocytes, and that's what protects us against polio, the more virulent wild type. That's why we don't have any wild type polio. But where you've got very low vaccination coverage and where sanitation is poor, then the excreted virus can circulate for long periods of time, and that allows that genetic change to a virulent strain. Normally in communities where vaccination coverage is high, there's no time for that degree of genetic mutations. The estimated incidence is about 1 in 17 million, so it's extremely rare, as you can see. But there have been outbreaks in these countries, as well as PNG, in DRC, in Indonesia, Mozambique, in Niger, Nigeria, Somalia, and Syria. There have been outbreaks of vaccine-derived polio virus, and the reason is always the same: that vaccination coverage in certain areas is extremely low, and there's poor sanitation and hygiene, and the virus can be excreted through this cycle of fecal oral spread around communities. So the response to that, which is eliminated vaccine-derived polio, is twofold. One was the mass vaccination campaigns, and the other one was the addition of the second dose of IPV. Remember, the IPV is inactivated; it can't cause vaccine-derived polio, but it's trivalent, so it'll mop up any vaccine-derived polio virus that's existing in the community. All right, and so this eventually will all switch to IPV, as occurs in many other countries, but that may take some time before that the final switch occurs. Okay, so this is what the polio schedule looks like now. Just so as you understand, there's at 1, 2, and 3 months is the OPV, and that's bivalent 1 and 3. So poliovirus 1 and 3, and 2 drops orally. The next phase is the IPV, and one of those doses is given with the third dose of OPV with the third dose, so both given together, and the other one given at 9 months of age. Right, and they're given intramuscularly, and that strategy will exist until we change completely to IPV. Okay, I just want you to see this video. I'll just show you again. It's important to be able to recognize this, what this child has. Yeah, it might be without knowing what this disease was, people might think that this is a form of seizures, which it could be. It could be a form of convulsive seizures. But what I wanted you to see from the video is how much it's the same muscle groups moving all the time, and that's characteristic of tetanus. So this young boy has tetanus, and what you could see from the video is that it's the same muscle groups that are affected by the tetanus all the time. Sometimes this young baby also has tetanus. This boy had tetanus from a tetanus-prone wound, and this young baby, of course, has neonatal tetanus. And you can see how the face is markedly affected by tetanus. The baby's face is screwed up, and also the baby has muscular spasm of the limbs as well. The vaccine for tetanus has also been around for a very long time, and remember I said it was part of the DTP, diphtheria, tetanus, pertussis, or the triple antigen vaccine. It's now part of the pentavalent vaccine, so DTP, that is diphtheria, tetanus, pertussis, and Haemophilus influenzae type B and hepatitis B. Now, the tetanus vaccine, we've talked about live attenuated vaccines, and we've talked about inactivated vaccines. Well, the tetanus vaccine is also an inactivated vaccine. It's a toxin, which means it's a protein that's inactivated with formaldehyde. So it's part of the tetanus toxin, but it's only part of it, and it's inactivated by formaldehyde, and that produces the toxin. Now, because it's not a very immunogenic protein, then there is an adjuvant attached to it. And an adjuvant is something that boosts the immunogenicity of an antigen. The antigen being the protein or the toxoid, and the adjuvant. The reason why the DTP was first developed is because the vaccine against Bordetella pertussis acts as an adjuvant. It acts as an immune stimulator. And so the combination of diphtheria, tetanus, pertussis leads to a much stronger immune response than if it's simply tetanus toxin alone. The tetanus toxin, when it is, it also, tetanus toxoid, the univalent tetanus toxoid also has an adjuvant. That's usually alum, an alum antigen adjuvant that stimulates the immune response. Now, the important thing to know about tetanus vaccine is that it doesn't stop Clostridium tetani, the bacteria that causes tetanus, growing in a wound. And so it's really important that if you have a tetanus-prone wound, regardless of how well a person is vaccinated, then you have to make sure the wound is clean. So proper surgical cleaning of a wound is the most important thing, even in patients who are tetanus immune or close to being tetanus immune. But almost any wound can be tetanus prone, as in it can lead to tetanus, almost any wound, apart from very clean minor wounds. But the wounds that are most tetanus prone are these. So compound fractures where there's dirt got into the wound, animal or even human bites, that they're particularly tetanus prone. If a wound contains a foreign body, or the wound is contaminated by soil or by horse manure particularly, or dust, then it's a wound is particularly tetanus prone. Or wounds that have a lot of tissue damage. So if you have a penetrating crush injury from motor vehicle accident, or you have a severe burn, any wound that's not clean is tetanus prone. But you recall the small child I showed you before, who had okay. You recall the small child I showed you before having those tetanic spasms. Well, this was the wound on his foot, and this was just a nail, a sharp nail that had gone through his foot, and it doesn't look like a very dirty wound, but you can see that even a relatively minor wound could lead to quite severe tetanus. The incubation period is about 10 days, but it can be anywhere from, if you get a lot of inoculum of tetanus toxin into the body, then it can be relatively short, or it can be much longer. And so if a person develops tetanus within a few days of having a wound, then often they have a large toxin load. Or if they develop it a bit late, and often it's much more severe than if they develop it a bit later, but the average is about 10 days. The tetanus immunisation is 3 doses in infancy and a booster at school level, and that provides protection into adulthood. If you've had a particularly tetanus-prone wound, like I mentioned before, then if you haven't had a vaccine for 5 years, then you should have a booster vaccine at the time you have a tetanus-prone wound. If you're only partially vaccinated, that is, say you've had 2 doses, or the person is unsure, or it's more than 5 or 10 years ago, then you should vaccinate you should give tetanus toxoid, and ideally the person should have tetanus immune globulin. So tetanus immune globulin is not available everywhere, but it's very important if you've got a bad tetanus prone wound and the person is poorly vaccinated, because it takes some weeks for tetanus immunity to develop, usually at least a week or 10 days. And in the meantime, to protect against tetanus, then ideally using tetanus immune globulin. But certainly for unvaccinated people, they need to be immunized. For an adult, certainly if you haven't had a vaccine for 5 years, then haven't had a booster for 5 years, and you've got a tetanus-prone wound, then you should be boosted. There have been some recent changes to the tetanus booster schedule, and the changes happened because what we used to use, tetanus toxoid, which was the commonest for several decades, we used tetanus toxoid. That is rarely manufactured these days, so there's not too many suppliers of just univalent tetanus toxoid. So now we're using tetanus diphtheria, and that also acts as an adjuvant. It's not because it's more effective, it's just because it's more available. So it's TD, tetanus diphtheria vaccine, and it comes in a 10-dose vial. The storage requirements are the same as for tetanus toxoid, so store at 2 to 8 degrees. Never freeze a tetanus vaccine, just 2 to 8 degrees. And you can use, if you open up a vial and you just use 1 dose, you can keep that vial for a month or 28 days, as long as you maintain the cold storage of the vaccine. I want you to have a listen to this. Okay, that's a baby I recorded, just sound I recorded, who obviously has pertussis. The background sound you heard halfway through was a nebulization, but you could hear from that the whooping cough that the baby has, the staccato cough, the paroxysms of cough that the baby had. I want to talk a bit about the pertussis vaccine. Remember, pertussis is traditionally part of the triple antigen, diphtheria, tetanus, pertussis, and now it's part of the pentavalent vaccine. Pertussis, of course, is highly prevalent. It exists in all countries, and it's highly infectious. If you're not immune to pertussis and you come in contact with somebody who has pertussis, then there's a 90% chance that you'll acquire the infection. There are very frequent outbreaks of pertussis, and I've just listed 3 that I know about in Papua New Guinea and the Solomon Islands that have occurred, quite large outbreaks in most of those places, and pertussis occurs in many places, always because of low vaccination coverage, of course. Pertussis is caused by Bordetella pertussis, the gram-negative pleomorphic bacilli. Pleomorphic just means it's not just a straight bacilli like an enteric bacilli, but it has it's like a coccobacillus in some ways, a bit unusual in shape. As you know, pertussis is the biggest risk, causes the biggest risk to young infants and often that's before the 2nd dose. So even if you're vaccinating at 1, 2, and 3 months, quite early in infancy, 1, 2, and 3 months, if a baby gets exposed to pertussis at 6 weeks of age, then they've only had at maximum 1 dose of pertussis vaccine, so they're not fully protected, and pertussis causes a very big risk to neonates. because it will often cause apnea and severe pneumonia. The biggest reservoir in the community is adults and adolescents who aren't immune anymore. And that's because, unlike other vaccines that we've talked about, the tetanus vaccine to some extent, and certainly the measles vaccine produces lifelong protection. The pertussis vaccine wanes in immunity over time. And so by the age of 18, even if you've had 3 doses of pertussis vaccine in infancy, then many adolescents from 15 onwards will be no longer immune. And so many countries have brought in a adolescent dose of pertussis vaccine to try to boost the immunity of adolescents and young adults, especially young mothers and fathers who might pass it on to their newborn babies. So that's important that you know about the waning immunity of pertussis vaccination over time. The treatment of pertussis, as you know, it can last up to 100 days. The infection in China, it's called the 100-day cough. But treatment with antibiotics, given it's a bacteria, can reduce the period in infectivity, but it may not actually reduce the duration of coughing. But it can be useful to treat with azithromycin because it reduces the risk of infectivity. That is the chance that a person with pertussis will pass it on. I usually treat both the index case and family members, and I immunize everybody. And if a young infant is hypoxic or having apnea or not feeding well or any other complication like seizures, of course, they get admitted to hospital. But most babies with pertussis, unless they're young or hypoxic or apneic, then they can go home, because it's best not to keep children in hospital with pertussis if they don't need to be, because they'll just pass it on to somebody else. All right, so that's pertussis. We can talk a bit more about it if you like. This obviously is a erythematous maculopapular rash in a child who's got conjunctivitis. Again, this child with conjunctivitis. This is measles, we will talk about clinical measles at another time, but I wanted to talk about the measles vaccine today. I mean, measles vaccine was one of probably the most important vaccine in the EPI when it was first developed, the expanded program of immunisation. And measles vaccine has been available since 1982, so 40 years now of measles vaccine. Ideally, unlike some vaccines, you can get very good population or herd immunity by, even if you've got 2/3 coverage, like 60% coverage. But with measles vaccine, you really have to have very high coverage. It's an excellent vaccine because it produces near lifelong immunity, but you have to have very high coverage. And anything below 85% coverage means that you'll still have some risks of having outbreaks. So in PNG, the measles vaccine schedule for many decades has been twofold. One is a 6-month dose, and that was introduced because in the early epidemics in the 1990s and even before, then the children most likely to get and die from measles were infants in the first 6 months of life. And what that meant was that's why the 6-month dose was brought in to try to protect infants in the second 6 months of life from developing very severe measles. But the problem is that the vaccine is not very immunogenic before 9 months of age. And so when we think about the vaccine coverage of measles vaccine, then we need to be thinking about what proportion of babies 9 months of age and older are immunized. Not so much what proportion of babies at 6 months are immunized, because even if a baby's immunized at 6 months, only a smaller proportion of that population will actually be protected. And that's why we need to be vaccinating children at 6 months, but also at 9 months. The 9 months dose is very important, right? And the reason why the measles vaccine doesn't always work at 6 months of age is because many children in the first 6 months of life still have residual maternal antibodies, and that inhibits the vaccine working. The baby is protected because they've got the mother's antibodies, but it can block the vaccine from working very well. And so we know that a proportion of babies have maternal antibodies, and that can lead to the vaccine not working as well. But at 9 months of age, very few, if any, babies have maternal antibodies left, and so therefore they respond much better to the vaccine at 9 months. And in some countries, the vaccine schedule is the first dose is given at 12 months of age. In most countries, actually, it's given at 12 months of age, because we know that almost 100% of babies will respond to measles vaccine if they get it at 12 months of age. There were some studies done on this in PNG, and only about a third of babies at 6 months responded very well with high levels of protective antibodies, and most of the ones that didn't respond with very high levels had some immune response, but they had some inhibition of the immune response because they had residual maternal antibodies. Now, the question, I think it's important that we understand why measles outbreaks actually occur. And they occur because if you've only got 80% of the population, for example, that are covered with measles vaccine, 80% of the population protected, then 20% of that population is susceptible. And over time, that susceptible population, because you've got new babies being born all the time, then 20% in 12 months' time becomes 22 or 3%, and in a few years becomes 25%. And as that susceptible proportion of the population grows, then measles outbreaks at a large scale can occur. I'll try to show this graphically in a minute, but we know that if the coverage is more than 80%, then the intervals between the outbreaks is much larger, sometimes somewhere between 4 and 8 years. But if the coverage is less than 80%, then the interval between the outbreaks is somewhere between 2 and 4 years. And that's been the problem in many countries, in PNG for many years, is that because the coverage has been lower, like around 65% or even less for the 9 months dose, then the interval between outbreaks is actually quite short. And so it's a bit like this. If you've got coverage at 80%, then over time, this is years on the x-axis and the percentage of coverage on the y-axis. And over time, if your coverage is 80%, then the coverage rate drops off, say to 65%. And that may be the threshold for an outbreak. And so if you've got you've got measles virus occurring in the population, then you'll get an outbreak. Then what happens is people within the population develop immunity, either because they're vaccinated or because they have natural immunity from the infection. And then your coverage rate of immunity goes up to 80%. And so if you've got a higher level of coverage, 80% or above, then the time between outbreaks can be quite long. If you've got more than 90% coverage, then you may not have outbreaks at all, because you'll maintain a high coverage. The problem is if you've got quite low coverage, like in the graph at the bottom, this is the number of years, and you can see that if you start off below 80%, then it doesn't take very long for the baseline coverage to drop below the threshold for which an outbreak will occur. And then you've got coverage every couple of years. And that's a situation that you don't want to have. You want to try to maintain very high coverage so that either you don't have outbreaks, or high enough coverage that you can have outbreaks only every 6 or 8 years. But at the moment, it's of great concern that the baseline coverage is low, and it gets lower, of course, every year because of the new babies that are born. I can explain that further if people don't fully understand that, but and I'll send the slides around. to successfully control measles, every country in the world, even whether they're rich or poor countries, they've all had to do the same thing. Well, they have to have high routine immunisation coverage, and then every country that has controlled measles properly has had to have some type of mass vaccination campaign, at least at the start. So if you've got 95% coverage, then you might only have to have one mass vaccination campaign, and then you'll be okay. But if you've got lower vaccination coverage, maybe 80 to 90% coverage, then you might need to do mass vaccination campaigns every 3 or 4 years to interrupt measles transmission. Remember, I said you need at least 2 doses, one of which being after 9 months of age. The dose at 6 months is important to protect infants, but it's the dose at 9 months or 12 months that is the most important, because that's the one that's most likely to lead to immunity. And WHO now recommends a second opportunity to be vaccinated. And by a second opportunity, I mean one at 18 months of age. Sorry, there's a second opportunity for vaccination at 18 months of age or at school entry. Some countries do it at school entry and other countries do it at 18 months of age. So you need to have a dose of measles vaccine from 9 or 12 months of age, another dose at 18 months of age or at school entry. You need to have some sort of supplemental immunisation campaigns, either one big mass campaign or one every 3 or 4 years. And you need to improve routine vaccination coverage, and you have to have effective case finding and disease surveillance, and that's what AFR, acute fever and rash surveillance, is about. So countries need to have all of those 4 things working well to interrupt the transmission of measles. Even if you have lower coverage, it's important to realize that every child you vaccinate helps, because even if an outbreak of measles occurs, if a child who's been vaccinated with 1 or 2 doses of vaccine, even if they get measles, then they're very, very unlikely to die of measles. So in an epidemic that occurred between 1999 and 2003, there were lots of children who died, and almost all of them were unvaccinated. And there were many children who got measles despite having 1 dose of vaccination, and none of those children died. And so the point is that vaccination will protect you not just against getting measles, but very importantly from having severe measles or dying from measles. So we shouldn't think that just because a child gets measles, if they're vaccinated, that it's a failure of the vaccine, because they're very unlikely to die of measles. That's important for health workers to know. Now, along with the measles vaccine now, there's been a change in the measles vaccine schedule in recent years, and it's to protect against this disease called congenital rubella syndrome. And these are some babies that have congenital rubella syndrome. You can see this baby's a preterm baby with a cataract. And this baby, you can just see, I hope you can just see the fine maculopapular rash that the baby had. So babies who have congenital rubella syndrome have microcephaly. This baby had quite a small head. 60% of them have hearing loss. They have cataracts like this, or glaucoma. They often have a squint like this baby's got. They often have cardiac abnormalities like a patent ductus arteriosus or pulmonary stenosis. And they often have petechiae or erythematous rash. And they often have a abnormal pigment on their retina. And this is the retina of a baby with congenital rubella syndrome. And that's, as I said, these babies are often blind. And it's this what's called salt and pepper retinopathy, where it looks a bit like, you can see the almost amillary pattern throughout their retina of this grayish brown pigment throughout their retina. That's the feature of congenital rubella syndrome. Now, for years, we just used the measles vaccine. So simply the univalent measles vaccine. But in 2015, the MR vaccine was introduced, and that's the measles rubella vaccine. It was the first vaccine introduced to prevent congenital malformations. It's not so much designed to prevent rubella, the infection, although it does, of course, do that too. It reduces the risk of getting the viral exanthem that is rubella in children, infants and children. But it was primarily introduced to protect against congenital rubella syndrome, which leads to significant mortality, but also long-term severe disability if a child is severely intellectually disabled, has microcephaly and blindness and deafness and cardiac dysfunction. So it was introduced to prevent congenital rubella syndrome. Now, at this stage, we don't know the incidence of congenital rubella syndrome. In most countries, it's not clear what the incidence is, but we do know that it's much higher in communities where rubella vaccination, where other viral exanthems like rubella and like measles are common. Again, just like with measles vaccine, if you maintain very high coverage, 85% and above, then you'll virtually eliminate CRS, congenital rubella syndrome. So you need to know that's why the R is in the vaccine schedule, rubella. We have a AFR surveillance, which I mentioned before, acute fever and rash, and there are many different causes of AFR, acute fever and rash, that erythematous rash that I showed you the picture of before, the measles being the most important one, but also rubella. And then we've talked a bit about other causes of rash, like parvovirus, that produces a particular sort of rash, HHV6, human herpes virus number 6, that produces a disease called roseola infantum. And then some forms of typhus, which is a bacterial infection, which can leads to an erythematous rash, and then enterovirus, which is actually very common as well, probably more common than typhus, but enterovirus causing what's called hand, foot, and mouth disease. That's often occurs in young children, in toddlers and school-age children. And then, of course, plus congenital rubella syndrome. So the AFR surveillance is really targeted mostly against measles and a bit against rubella, and certainly against the CRS, congenital rubella syndrome. But all of these other viral exanthems and bacterial infections can cause a syndrome rather similar to measles, with an erythematous, widespread erythematous maculopapular rash. I wanted to briefly talk about hepatitis B vaccine. Now, the rubella vaccine was the first vaccine that was introduced to protect against the congenital malformation, and the hepatitis B vaccine was the first vaccine that was introduced to protect against adult disease, particularly cancer. Of course, hepatocellular carcinoma being the main one, but it also protects against chronic hepatitis and cirrhosis of the liver. But importantly, the primary reason was to protect against hepatocellular carcinoma in adults. And the risk is very high. If you're a chronic carrier of hepatitis B from infancy, from the neonatal period, from vertical transmission, then you have quite a high risk of getting chronic active hepatitis and hepatocellular carcinoma later in life. So a very important vaccine that why we should give it in the birth dose of the hepatitis B vaccine is very important to protect against vertical transmission. Now, we've talked about live attenuated vaccines. We've talked about inactivated protein vaccines, protein particulate vaccines. We've talked about adjuvants, and hepatitis B vaccine is a bit like some of the COVID vaccines in it's a recombinant vaccine. It's made by the insertion of DNA into cells, which then produce the protein that initiates an immune response. So it's called a recombinant vaccine. It's not live. It can't cause, the hepatitis B vaccine cannot cause hepatitis B. It can't cause any disease, but it is a recombinant protein vaccine. And the main reason, as I said, is to prevent the vertical transmission of hepatitis B virus, because chronic carrier status with that can lead to hepatic disease in later life. It's inactivated, as I said, and it's ideally given in the first 24 hours and then 3 doses. Now, so I've talked about the first 6 vaccines to be introduced as part of the EPI, and I've talked a bit about hepatitis B vaccine, which came in the 1990s. And then since 2000, there's been 2 other vaccines that have been introduced, and they are vaccines against pneumonia and meningitis. Now, these were not part of the original EPI schedule. The Hib vaccine, Haemophilus influenzae type B vaccine, was introduced in 2008, and the pneumococcal vaccine, the conjugate pneumococcal vaccine, was introduced in 2014. But for many decades, both of these infections, pneumonia and meningitis, of course, are in the top 5 causes of admission and deaths every year. And about 40% of our meningitis cases were due to pneumococcus, and about 40% were due to Hib before the vaccine came in. Similarly with pneumonia, about 20% of pneumonia cases are due to pneumococcus, and about 15 to 20% are due to Haemophilus influenzae type B. So these vaccines were highly effective in reducing particularly meningitis, less so for pneumonia, but particularly meningitis. The Hib vaccine, as I said, was introduced in PNG in 2008, but it's sort of been introduced in other countries in around about that time. It was first licensed in the late 1990s after a big study in the Gambia in West Africa. It's part of the pentavalent vaccine, diphtheria, tetanus, pertussis, Hib, and hepatitis B. And it's highly effective against Haemophilus influenzae, particularly invasive pneumonia and bacteremia and meningitis. And the good thing about hepatitis B vaccine is that, unlike with measles, where you have to get very, very high rates to get elimination of the virus, even if you get about 2/3 of the population immunized with hepatitis B vaccine, you'll probably get adequate herd immunity to eliminate Haemophilus meningitis, not the pneumonia, but certainly you'll virtually eliminate Haemophilus meningitis if you get 2/3, so 63% of the population immunized against with Hib vaccine. Of course, it's better to get a higher coverage than that, and then you'll certainly get elimination of Haemophilus meningitis. But if you can get 2/3, then you get elimination. The pneumococcal vaccine is different because it has, I think we've talked about this before, but it was introduced in 2013 and 14. And there was a pneumococcal vaccine before the conjugate pneumococcal vaccine, but that wasn't very effective in young infants. And so it was used in the 1980s, but not very effective. And that's why this is called a conjugate vaccine, because it links a protein conjugate with the polysaccharide. The polysaccharide is an outer covering of the pneumococcus, the bacteria. It's covered in a polysaccharide or a sugar covering, but that in itself is not very immunogenic. But when you link it with a protein, that's why it's called a conjugate vaccine. And usually it's linked with a tetanus toxoid. So there's some other toxoids used, but it's a protein linked with a sugar. So protein and sugar together is very immunogenic. That's why the pneumococcal vaccine was much later to be developed. So it's a polysaccharide antigen, a sugar antigen linked to a protein. And it's a bit like the Hib vaccine. That was the first conjugate vaccine. And then the conjugate pneumococcal vaccine was introduced. Now, as I say, the pneumococcal vaccine is a little bit different because the Hib vaccine is against only one strain, Haemophilus influenzae type B, but the PCV vaccine is against 13 strains. Now, that's 13 out of a total of 90 different strains of pneumococcus that cause disease. And I won't go through this in too much detail, but the type of strains that have been chosen for the pneumococcal conjugate vaccine is those that there are 90 different strains of pneumococcus, but not all of them are equally pathogenic. And so these are in every country can have their own league table, if you like, of pathogenic strains. But these are the common strains causing infection in children in Papua New Guinea. Every country is a little bit different, but mostly they're similar to this. And this is the 13-valent conjugate pneumococcal vaccine, and it covers most of the strains, but there's one or two that are missing. All right. Now, before PCV 13, there was a 7-valent vaccine, but that didn't cover many of these strains, and so it wasn't very effective. But the 13-valent vaccine covers a lot more of the pathogenic strains than the earlier conjugate pneumococcal vaccines did. More than 80% of the pathogenic strains. So we can expect the conjugate pneumococcal vaccine to be highly effective, at least in preventing pneumococcal meningitis in Papua New Guinea. I won't go through this, but it's just, this was the study done that led to the licensing of the vaccine, and it was done in the Gambia, like the Hib vaccine studies, and it was found to be highly effective against pneumococcal meningitis and a bit less effective against pneumonia, but highly effective against pneumococcal bacteremia. So if you've got pneumococcus in the bloodstream, either leading to bacteremia or meningitis, then the conjugate pneumococcal vaccine is highly effective against that. Not so effective against clinical pneumonia, where the etiology of infection is a bit different, more drip aspiration from the nasopharynx. Okay, so we've nearly finished. We've talked about the 6 vaccines that were introduced. First of all, we talked about smallpox, and then the expanded program of immunisation, the 6 vaccines that were introduced in 1977, and then expanded in the 1990s to add hepatitis B vaccine, and then subsequently in the 2000s to add the conjugate vaccines against Haemophilus influenzae and pneumococcus. And then, as I said, some countries in the last 10 years have introduced the HPV vaccine, the human papilloma vaccine, as the second vaccine to prevent cancer. A very important vaccine, I think. It protects against cervical cancer, of course, very important vaccine to be given to young adolescents, girls and boys. And then some countries have introduced the rotavirus vaccine to protect against gastroenteritis, rotavirus being a cause of at least 1/3 of all cases of severe gastroenteritis. And then, of course, we've recently had the SARS-CoV-2 vaccine, which many countries are using for children as well. So I'm going to stop there. I think that's all we want. Oh, yes. So finally, back to the schedule. And I wanted to explain why the schedule is like it is, and why we give all of these vaccines. And I hope that's been useful for you today. I won't go through each of them today now, but that's the schedule, and explains why the schedule is like it is. All right, I'm going to stop there. If there's any questions, I'm very happy to answer any that you might have. Each country has a slightly different vaccine schedule, I know, but that gives you an idea of the historical development of the EPI and why we vaccinate against those particular diseases. I hope that's useful to you.